In this series, my team of experts and I will walk you through every step of the surrogacy journey, from your first application all the way through birth and recovery. Over the past 5 years, we've helped hundreds of women through their own surrogacy journeys, and countless intended parents reach their dream of parenthood. Surrogacy is my life's passion. It's one of the most selfless and life-changing gifts a woman can offer another family. But it's also complex and emotional. That's why we've created this series, to educate, empower, and help you feel confident in each phase of the journey here at Alcea. Whether this is your first journey or not, there's so much to learn, and we're here to support you every step of the way. This video covers IVF, cycling, and pregnancy. All right, so you've been pre-screened, you've matched with amazing intended parents, you've gone through medical clearance, you've signed your legal agreement, and it's time for embryo transfer. RN's gonna talk us through a little bit more in depth about this process.
Hey guys, I'm Christina. I'm one of the nurses on staff with Alcea. This is one of the absolute most amazing times of this entire part of your journey. Leading up to transfer, all the steps that you're going to take to get to the big day of the actual embryo transfer itself. The timeline for this can vary a little bit depending on what your transfer date is going to be, which will be dependent on quite a few variables. Of course, you need to agree with your intended parents on the timeline that you're looking for. If there's a specific month, you go by your blackout dates. The clinic will absolutely ask you what dates would work for you, which dates wouldn't. So when they do start your calendar for your cycle, when you're cycling, you're gonna have different medications, and they will tell you when to begin each of those medications depending on when the transfer date will be. So you could be talking about transferring 3 to 4 weeks later, or you could be transferring a few months later depending on that date that is ideally set.
And that's 3 to 4 weeks or months past the time that you've executed the legal agreement.
Yes.
And oftentimes the legal agreement will have a time frame within it. So you have all agreed to what time frame works best for all parties. So you're well aware within that legal process when you will move to an embryo transfer, which, as she said, could be as quick as the next month, but could be a few months out depending upon other extenuating circumstances. We know this is a super complex piece of the process. Most surrogates have never had to use medication or an IVF doctor to get pregnant on their own. And so our clinic coordination team kind of kicks this process off with what we call the pre-cycle connection. The attendees of this meeting are going to be the surrogate, the intended parent, both case managers, and our clinical coordination team. Christina, what do we talk about on this meeting? What do we do to help everybody prepare?
So everyone will get together via Zoom, and we will discuss the different parts of getting prepared for the actual cycling and embryo transfer itself. We want to make sure that everybody is on the same page as far as if you're going to use insurance, and if you are, which kind you're going to be using. Most people will not be using insurance during their cycling, during the medications, during the monitoring period. Everybody is a little bit different, but we're just going to keep that in mind. We're going to discuss that to your specific needs on that Zoom call itself. So
we don't want you to get to the appointment and then refuse to see you because payment hasn't been taken care of. So this meeting is about all those little logistics that, because you haven't done this before, or even when you have done this before, there aren't any hiccups. Because prior to going to the clinic for embryo transfer, you're going to have to locally be monitored. You'll usually have anywhere from 4 to 8 blood draws, and then anywhere from 3 to 6 ultrasounds to make sure that the medications you're taking are doing what they're supposed to do, and that they are building your lining and your estrogen, progesterone are the appropriate levels to move towards hopefully a successful transfer. So we have that pre-cycle, we kind of discuss the calendar, where you're monitoring the medications. So I know that IVF medications, it's kind of a broad term. Can you talk to me a little bit about what different types of protocols you might see based on clinics and the different mediums of those kinds of medications?
So each clinic has its own protocol. Overall, the goal is the same in the end. We want to make sure that your hormone levels are ready for a transfer, for the embryo to get nice and comfy inside your uterus. So most of the common medications that you will probably come in contact with are possibly birth control pills to start. So you'll take a pill each day. They'll tell you which day to start the pills if you're not already on them. They'll tell you which day to stop them. Another common medication that you might be on is called Lupron. Lupron is a sub-Q, or just under the skin into your fat. It's a medication. They want to suppress ovulation. So
it goes in your abdomen.
Yes, it goes into your abdomen. Nice little cushy spot. That medication, it's a pretty small needle. It's pretty straightforward. It's one of the easier ones that you will be on if you are on Lupron. So each medication also has side effects that we will discuss too when you have your pre-cycle connection. So if you have Lupron, that'll be the next step. Another medication will be estrogen. Estrogen comes in different types of, in different forms as well. So you might have the same type of subcutaneous injection like the Lupron, where it just goes into your belly, a little shot. You could have an oral form where you're taking pills, or you can also have some type of suppository where you could be having to insert the medication up into your vagina. So there are different forms of estrogen. The clinic will let you know which one, or sometimes you're on a combination of different types of estrogen as well.
Essentially, what these medications serve to do biologically is strip down your lining to as thin as possible so that it can fluff it up and make a really safe and healthy environment via the progesterone that you're going to add into the protocol later. So the early stages of your protocol are to thin your lining, you'll have a good bleed, and then they'll begin your progesterone. But you'll have to be going to that local monitoring facility that we mentioned as you're taking these medications so that they can maybe tweak the doses, add, take away, and when they know that you're ready to actually begin the progesterone, which will be what then prepares the body for pregnancy.
Correct. So during this entire time, you will be going for a weekly or sometimes a few times a week, depending on what your needs are and how your levels are looking. They will check your blood work. They want to check your levels. You want to make sure your hormones are at the place where they need to be an optimal dose. So they could actually ask you to increase your dose. They could ask you to decrease your dose depending on how those blood draws look at that time. In addition, they will also be looking at your lining of your uterus. So they will be using that internal probe to check the lining and see what the measurements are. They want to make sure, again, that it's at the perfect condition for the embryo to eventually transfer.
And I think this is a really good time to stress a really important point. The kind of medications that are used in IVF are not typically something that you're going to find at a local CVS or a local pharmacy at all. When you get a calendar from your IVF clinic, which will be one of the very first things that happens once you're legally cleared, they're going to issue a transfer calendar to you and your intended parents. That calendar will be available to you in your parent portal or your surrogate portal. It'll also be emailed to you in PDF. I'd stick it on your refrigerator so you have it top of mind every day. And it's going to guide you every day on the dose of the medication that you're taking, the way you're taking it, and when you're supposed to go and monitor to make sure that the medication is doing what it's supposed to. But I mentioned that medication cannot be obtained locally because you really have to be on top of it. If you know you're going to be running out tomorrow and you have to get that from a pharmacy that is a mail-away pharmacy, that's going to become incredibly difficult. So part of that discussion is going to be who is your pharmacy and what is the lead time of that pharmacy. So if you know you've got 5 estrogen left and it might take 3 days to get estrogen in the mail from your compounding pharmacy, you need to be proactive in letting your case manager know that we need to get that ordered sooner rather than later, because it is not always possible to find those locally, and not taking those medications the way that they are prescribed can scratch the whole cycle. It is very important that you follow the rules of the dosage, of the monitoring, and that you do exactly what that calendar says, and then also what that physician tells you once they get those results. Yes. In addition, those monitoring appointments that you're going to, they're often going to ask you to go very early in the morning, like 6:30, 7 a.m. before the clinic even opens. And it's imperative because we need same-day results. We need to get those results back the same day to make sure that you should be continuing on the same kind of medication and that they don't have to make any kind of tweaks or adjustments. And I think these two things are new for most surrogates, and it's something that we really talk in depth about in that pre-cycle connection, and it's something that you need to be remembering as you're going through and preparing for that transfer.
Absolutely. Usually these pharmacies will set you up with some type of app where you can actually refill your medications by yourself. They will have a card, the agency will put a card on file, so your medications will be paid for. You don't have to worry about the payment for them. Most pharmacies will actually overnight the medications, but you have to keep in mind as well that not all pharmacies are on the same time zone that you're in. So you have to keep that in mind. So if you do need an overnight shipment, you can't guarantee that ordering it today, it will be here tomorrow. And sometimes there's delays, there's weather issues. So always look at how much you have left and be proactive and order them in advance. Or if you need help, to make sure you let your case manager know that you need a refill, and they will take care of that for you. And then going to your appointments early in the morning is crucial, like Angela mentioned. You want to make sure that we have those same day results so you don't scrap the cycle. The clinic might ask you to take a picture of the lining of your uterus and have you send it to them so they can actually read it right then and there. And they'll have access to those results sooner than when the clinic is able to fax them over. So if you're able to, each clinic's a little bit different, but if you're allowed to, taking a picture is sometimes asked of you if possible.
Yeah, but I really can't stress enough, I think Christina agrees, this is kind of a technical piece of the process. It's definitely one of the ones that most people are unfamiliar with and can be a bit complex. But we have several resources at your fingertips to help you through this, to make sure that you can, really follow all of those directions. You're typically on these medications for about 2 weeks before you have your bleed. You'll have your good bleed, and if all of your medication levels look normal, that's when they're going to enter in progesterone, which I know a lot of surrogates dread because typically the progesterone is a pretty large needle that is inserted into your rear. And it's something that you have to do every day from the commencement of that all the way through as late as 10 weeks of pregnancy. So it's a pretty cumbersome and lengthy medication. It's not always done via shot. Sometimes they do have progesterone suppositories, but this is the time that often people begin to see a little bit more side effects from the medication. That just is something that is obviously not pleasant. And we have a lot of resources, again, to make this a little bit more pleasant. We've got some pinned posts on our Facebook group. We have a video on YouTube already about some ways to make the progesterone and oil shots go a little bit smoother and a little bit easier. And your case manager can absolutely give you some tips and tricks. But Christina, so you've done all this monitoring, you've had all this medication, you've gone to these appointments, and now the monitoring facility has said everything looks optimal. You're ready for transfer. What happens?
Okay, so when you're actually ready for transfer, about 5 days prior is when you are going to start that progesterone, somewhere around there, depending on what day the embryo is going to be transferred into you. So the clinic will let you know which day to actually start the progesterone. And like Angela mentioned, you are going to be continuing that throughout the pregnancy for the first about 10 weeks, and then you're going to get off of it and you'll go about your day as normal, like with normal pregnancy. So when you're actually ready for transfer, you're going to go back to the clinic where you went to for your medical screening. So again, you need to be flexible with traveling and dates, and you should know ahead of time what those dates would be. However, once in a while, that date will be changed because your body wasn't either responding to the level that they needed it to, or they need to adjust the medications. So sometimes the transfer could be off by a few days to a week.
So there's some flexibility that's needed there. Also, some clinics want you to have your last monitoring appointment in person. So whereas some clinics will allow you to do your last blood draw locally, you do it locally and then fly to the clinic. Some want you to come out a couple of days before the scheduled transfer, so you have actually a longer trip. So it's really important that you're prepared with childcare. If you have a job that you need to get a replacement, or let them know that you're going to be out of the office, because clinics do it a little bit differently, and the expectation could be that you're there locally for the embryo transfer anywhere from 2 to 4, even 5 days. And it is required that you have a companion. And so all of that will be logistically discussed and prepared for you, but it is something that you need to remember when you start thinking about your transfer calendar.
That's correct. So the morning of your transfer, your clinic will give you instructions. Typically you need a pretty full bladder. That can actually be the most uncomfortable part of the entire transfer process, just because your bladder is going to be pretty full and for quite a bit of time. You're going to go in, you're going to have your full bladder. Some are a little bit more conservative than other clinics, so you're going to either change into a gown of some sort or have a gown over your lap, just so you're ready for the actual transfer itself. Some clinics allow you to have your intended parents with you, or one person or one support person. Some clinics don't. So you will be advised, to exactly what your clinic standards and policy and procedure are. When you go in for the transfer, they're going to put the internal probe in once more. They're going to double check, make sure that your uterus has the thickness of the lining that they're looking for. They want to make sure that they have the correct embryo. They'll ask you who you are doing this for and make sure that it's the correct embryo. So you'll have somebody come in, they'll go over all that with you. The doctor should walk you through the steps that they're going to take. They will put the catheter inside after the speculum is in, so they can actually see your full access, make sure that they can see what they're looking for as far as the placement itself. A little tiny catheter goes in. They drop off the embryo inside of your uterus. It's called a transfer. Once they transfer that embryo into you, they will have somebody go and double check just to make sure the embryo left the catheter and is now inside of you and in a good place. They will double check that, sometimes triple check it, because it's really important to make sure that it's in there and in the correct place.
What's super cool is that most clinics, you're going to be looking at a screen and you can see them physically put the catheter up inside your cervix and then push the liquid, and what's in that liquid is the embryo. So you can see the embryo, and the new type of technology kind of highlights the embryo so it glows a little bit. So you can actually see the moment that the embryo goes into your uterus, which I think is so cool to think about. The moment that embryo enters your uterus, you can see that now at most clinics.
And then at that point, you are considered pregnant until otherwise.
They kind of keep you on your back for usually 10 minutes. They'll keep you in that room, and then they'll wheel you over to a recovery room, although there's really not a lot to recover from.
They
let you go to the bathroom.
That's the most exciting part.
And then you get to go, and everybody says, take it easy for 24 hours.
Yep.
Most clinics say don't lift anything heavier than a milk jug for 2 weeks. And then in anywhere from 9 to 12 days, you're going to go and have your blood work locally to determine whether or not you had a successful pregnancy.
Prior to that, they'll actually have you go in as well to check your hormone levels again.
That's right, they will. So before that,
prior to the beta HCG testing, where they actually check your hormones for the pregnancy, they will have you check your blood work just for your the estrogen and progesterone levels, just to make sure those are good. And again, throughout this process, they might have you tweak the medications a little bit depending on how your body's responding to those two different medications.
I think one anecdote that I think is really important to stress here is we actually once had a surrogate who got pregnant and then she stopped taking her progesterone, and when we asked her why, she said, well, I never had to take progesterone for my own pregnancy. Why would I have to take it for this one? You cannot stay pregnant with an IVF pregnancy without progesterone support. You basically trick your body into thinking it's pregnant, so therefore you bypass the luteal phase. The luteal phase is when your body would prepare your body with progesterone. So until the placenta takes over at around 8 weeks, sometimes even 10 weeks, your body is not making the progesterone naturally that it needs to support a pregnancy. That surrogate went on to have a miscarriage a few days later. So it is critical that you follow the doctor's directives and that you take those prescriptions not only in the dosage that they are requiring it, but also at the time that they are requiring it. Because this is a science, and what they are doing is supporting your body to make it think that that luteal phase happened, that your body is pregnant, and then once the placenta takes over and starts to produce its own type of progesterone, that's when they'll begin to wean you off of the estrogen, wean you off of the progesterone, and you will be released to the OB like it's a traditional pregnancy. But during the IVF process, these medications are mandatory. These are not suggestions. You really do have to follow the protocol, or the pregnancy and the entire cycle is at risk.
Absolutely. So keeping yourself organized with their medications is key here. You're going to be on quite a few different medications typically, so finding a way that's going to work for you, whether it's some type of medication
app,
exactly, an app, different types of, they sell different types of products where you can organize pills, like a little pill sorter. And again, just making sure every single day you are looking at what's needed, how much. The timing is also important. You need to stick within an hour of the same time each day for these medications. So progesterone injections, you want to stick between, say, 8 and p.m., whether it's a.m. Or p.m., your clinic will let you know which time of day, but you want to make sure that you are staying within that hour or two of these medications as well.
Yeah, and I think it's now maybe a good time to remind everybody a not so fun part of this process, and this is definitely the abstinence period of your cycle. So no matter what clinic you're with, no matter what your contract says, there are weeks that you must stay celibate, and all of them are going to encompass the time of transfer. So it's typically from the time that you begin medications to the time that you either have a positive beta or a positive heartbeat scan. The clinics are a little bit different, but it's very, very important that you stay celibate during this time, because you're preparing your body for pregnancy, and it is absolutely possible to get pregnant and then go into your embryo transfer already pregnant and not know it. This has happened in the past. So it's critical that you not only follow your contract, but listen to your doctor, because there's risk for that particular element as well.
Absolutely. So after the transfer, they call this the 2-week wait. Sometimes, when you get pregnant on your own, if you want to take a home pregnancy test, there's a hormone in your blood that determines whether or not you're pregnant. During the pre-cycle connection, your coordinator, your case managers will go over if your intended parents want you to home test, and if they do they want to know those results? And if they don't, it is your body, you have the right to home test, but you want to make sure that you're respecting those your intended parents' wishes. So you could potentially find out if you are pregnant 4, 5, 6, 7 days post-transfer, but typically you won't have the confirmation via blood work until about day 8 to 12, depending on when your clinic wants you to go back in for that first blood draw. So there's a hormone in the blood, they're gonna draw your blood. If it picks it up, it's gonna tell them what that level is. And then again, you're gonna go about 2 days later for a repeat blood draw. And what they're looking for is that for that number, that initial number that they saw on the first blood draw, to at least double. The clinic will call you, they will call the intended parents to let them know if there was a positive result, and if so, what it was, and they will tell you what we're looking for, again, about 48 hours later. Sometimes it's about 3 days later. So somewhere in there, you will have confirmation from 2 different blood tests if you are officially pregnant or not.
One thing I want to just stress is, a lot of surrogates get online and look for support, which I think is amazing, and they start comparing beta results. Mm-hmm. That can really sometimes lead to unnecessary heartache. Beta results can vary wildly. Day 8 or 9 betas can be as low as in the 30s and as high as over 100. Those are both viable pregnancies. What your doctor actually cares about is the doubling number. So in 2 days, when you go back, how much of a percentage increase has happened? And obviously, that increase on a 30 versus over the 100, your number might be different, but the increase is what they're looking for. And so don't stress about other people's numbers. They had different kind of embryos. They could have transferred at a different time of day. Like, there are so many variables in this process. And I understand how easy it is to get caught up in this just stressful time. But you'll know with a good rising beta that your chances of moving on to the next step, which is going to be the ultrasound, are pretty likely. So now that you've had 2 positive results, you're going to move to an ultrasound. Talk a little bit about what the first ultrasound looks like.
Yeah, so Angela mentioned those numbers. I also want to stress the importance of not assuming you have twins just because of a certain number as well.
That's right.
Some people just have higher beta numbers. So also keep that in mind, that just because you have a beta, their first one could be 400. It does not mean there's twins in there. You will find out how many are in there during your first ultrasound. That first ultrasound will be around week 6. So if you have a transfer and it's a 5-day embryo, you're almost 4 weeks pregnant on the day of transfer. So week 6 is really just over 2 weeks after the transfer when you will have that first ultrasound to see if there is a heartbeat. Some clinics actually want you to go in around week 5 just to make sure the placement of the embryo is in a good place, but not all clinics do that. So you should expect between week 6 to week 7 for that heartbeat confirmation. When you go for that scan, you will see on the screen the embryo itself, and ideally you will start to see that first little flicker, which is like the most amazing thing for your intended parents and for the GC to see, because you are now officially bringing life into the world.
It's so very exciting to find out that you have a viable pregnancy and you see that heartbeat, but it's also the time when your base compensation is going to begin, and that's also an incredibly exciting time for every surrogate. They'll continue to monitor you at the IVF clinic for usually all the way up until about 10 weeks. But once you've had your second heartbeat ultrasound, they will begin to wean you off those medications. So it will typically start with stopping your estrogen, and then you'll start taking maybe a progesterone shot every other day instead of every day. And then eventually you'll be off all medications and you graduate over to your OB or the regular doctor, who will now treat this pregnancy almost identically to the way that your previous pregnancies have been treated.
So it's important to know that you actually get to pick your OB as well. So as long as you're seeing the provider of your choice, it's going to be at a level 3 or 4 NICU hospital. So sometimes you might have to pick a provider that you're not used to, but you still get to pick your provider in the end.
At Alcea, we know that this transition is also another complex time. Intended parents especially really worry about how they're going to be a part of a pregnancy that really by nature isn't theirs. And so we at Alcea engage that clinical coordination team again. We mentioned that pre-cycle connection. We're going to have a pre-OB connection. Same audience, surrogate, intended parent, both case managers, and someone from the clinical coordination team. Someone from that clinical coordination team will proactively have reached out to the OB's office and asked them, What are your policies and procedures about surrogacy pregnancies? We unfortunately at Alcea don't have control over other doctors' clinic procedures. And so we get a variety of answers. Some that are very open and you can have your intended parents there and present, and they're very excited to be involved in a surrogate pregnancy. Others are a little bit more bearish and have a lot more rules around what the intended parents can and cannot do, what information that they can get, etc. But what's most important is that we get all of the necessary HIPAA forms on file so that at a minimum, the intended parents can call the doctor's office and get the information about their baby. The surrogate will have to sign it, the agency and the intended parents. So even if you have a clinic that's a little bit more restrictive about the information about the surrogate, we want to make sure that we can create a conduit of communication between the doctor's office and the parents about the health of their child. On that pre-OB, we're not only going to talk about how the OB handles the pregnancy, we're going to talk about how we want to handle it. If we were IP and GC, like, are you planning to be a part of those appointments? If the clinic will allow, do you want us to video you in? Do you want us to be the one, the surrogate to be the one to tell you about that appointment? Or do you want to wait for that information from the doctor? There's all kinds of nuance about this. And what we're trying to do is create and cultivate a relationship that makes the intended parent feel a part of the process while still ensuring that that surrogate has all the bodily autonomy that is necessary and protected within this process. So typically speaking, how it works will be that the surrogate will have their own independent time with the doctor, and then in some form or capacity, the intended parents will be invited in to a conversation, to an email, to some part of that appointment, so they can still hear about what is going on, but they're not going to violate the privacy of anything that maybe I want to talk to the OB about privately that I don't want my intended parents to hear about. So we try very hard to prepare for that pregnancy, but really holistically, once you've weaned off the medications, once you've been released to the OB and we've had that meeting, this pregnancy is going to progress like all of your previous pregnancies. You'll see your obstetric provider 1 time per month until about end of the 2nd trimester. Then you'll start going 2 times per month. Then you'll start going weekly, and then eventually move to delivery. What sets Alcea apart and our decidedly different strategy to managing cycling and transfer really lies in our clinical coordination team. We have a dedicated group of clinical people who understand this process like the back of their hand, that interface with the clinic and the intended parent and the surrogate. You don't know what type of organization a clinic has. Some are wildly unorganized. Some are amazing and on top of everything. But the surrogate will always experience a consistent process because we have someone sitting in the middle that is skilled to take care of those gaps, to be transparent, to be proactive. And that clinical coordination team allows for consistency. And most agencies do not have that role or that team in place to take care of what I believe is one of the most critical pieces of the process.
I think another aspect that sets us apart that's really awesome is that both the GC side and the intended parent side each have their own case manager. So if you have a problem, if you have any issues, you have your own special contact to go to. You are never left alone, you're never left in the dark. If you ever have a problem, you always have immediate assistance with somebody who will help you, who will guide you through, and who, if there is a problem, eventually resolve it without you having to be embarrassed or uncomfortable.
Yeah, they're a neutral person, and all of our gestational carrier case managers are former surrogates. All of our intended parent case managers, if they're not former intended parents, they're people who have worked with intended parents for the duration of their career. And we learned very early on at Alcea that intended parents and surrogates need wildly different kinds of support. So having the appropriate resource support them that is safe and neutral, and then having them share people like the clinic coordination or the legal administration team allows us to have this full, well-rounded sense of knowledge, but still a safe primary contact for each individual that makes them feel valued, and it's a subject matter expert in their particular piece of this process.
There are a few challenges that you might face during this entire cycling process. You are going to have a little bit of pain or feeling uncomfortable from some of the side effects from the medications or the injections themselves. That's a little bit hard. It's a little bit, it's hard on your body. You have to get used to actually giving yourself a shot. Most people for most people, this is the first time ever having to give themselves an injection or take so many medications. And the hormones itself can make you feel pregnant from the beginning. So you're battling some of these side effects early on that only continue, through those first few weeks of pregnancy. So just keeping in mind that you're going to have some moments of you're very tired, you're exhausted, you're hormonal,
Yeah, you're getting pumped with synthetic hormones, and your body sometimes doesn't know what to do with that. And so we definitely hear feedback, and I definitely experienced my own side effects from certain medications. I mean, Lupron in theory renders you menopausal. It basically stops your ovarian function. And so some women will report that Lupron makes them feel things like hot flashes or itchy skin, because in theory, that's what it's doing, is shutting down your ovarian function to make sure that you're not going to ovulate and kind of not be able to move forward to the IVF cycle. The two big wins that we hear communicated from surrogates quite often are that heartbeat confirmation. That's also the beginning of compensation for them, which is really exciting. But most importantly, you're transitioning to your OB and your care provider. So all of this unfamiliar territory of the IVF, the medications, doctors you didn't know, that's over, and now you're ready to settle in to what you're really good at, which is being pregnant, because you wouldn't be here if you weren't a great pregnant person. So it's just moving to that next phase feels more comfortable and secure, and you get to start all the real fun stuff, the planning, the hearing the excitement of the intended parents. It just definitely is a huge win of this process. Thanks so much for watching, and please consider subscribing. In our final video of the series, we'll be covering the big day, the birth of a beautiful baby. We'll also dive deep into one of the least covered topics of our community, the postpartum experience. See you then.